Good evening, everyone, and welcome to the first EAUN webinar of 2023. Also, the first webinar organized by the special interest group of endourology robotics. The topic of the day is improving efficiency within the robotic theater. And I'm Marta, one of the surgical practitioners in London, and I will be one of the moderators of this webinar. With me, there is Anna, also a surgical care practitioner in London, and moderator of this session of today. Let's give a few minutes for people to join, and then we will go through the program of the day. We have 3 speakers today. The first session is done by Netra, who is an experienced theater nurse based in Bangalore, India. She will be presenting the first session on challenges in implementing a robotic service and developing a worldview, followed by Pam, who is a surgical care practitioner based in London. And she will talk about creating a successful robotic theater team. And we have as a third presenter, Claudia, who is a surgical care practitioner based in London. And she will talk about expanding your robotic service, a multi-specialty approach. At the end of the 3 presentations, we will have a discussion with questions. So feel free to write along the webinar, and we will answer all the questions at the end. Should we start? We have a few attendees here. So Nitra, I'll just let you share your slides.
Thank you, Martha, for the brief introduction. Good evening. I'm Sister Netra, working as an operating room in charge and a robotic nurse in EAU Hospitals, Bangalore, India. In today's talk, I'll be speaking about the requirement and challenges for the setting up a robotic service. And these requirements and challenges are specific to the Versius robotic system, as my experience is only with the robotic system. I have no conflict of interest to disclose. A brief about the Versius robot. It's a modular system with up to 5 independent arms, including a robotically controlled endoscopes, all working together and controlled from the controller on a surgeon's console. The modular design allows the system to be easily portable between the operating rooms. The system has an open surgeon console, which allows the surgeon to operate either in a sitting or standing position. The requirements can be broadly classified as physical, environmental, as in CSSD requirements. Let us go through one by one. Though the company states that the required operating room layout is around 100 square feet, based on our experience, I would say that the operating room should have a minimum 300 square feet to work comfortably. Here, the space is not only for the robotic. When we add on the equipments and the OR team, the need for the space is more obvious. I'm sure any modular operating rooms will have these. And in one of our older branches, we needed to add the additional land ports as it was an older building. Achieving temperature and humidity is not a concern in our setup, as we work in a city with a lower humidity. All diathermies are not compatible with the Versius robot. At present, these are the compatible modules. And if you're going for a new robot, you may have to keep this in mind. It's mandatory to have a storeroom adjacent to the operating room where the robotic components to be stored and serviced. The door of your storeroom should be at least minimum 3 feet for the console to go in through. This may be a challenge in the existing hospital if they do not have an additional room adjacent to the operating room. These are additional CSSD requirements. For us, the RO pipeline was a challenge, as we did not have this and we have to do this externally. And our air compressor, we have to realign to generate exactly a 5 mm pressure which is the requirement for the drying the robotic instruments. And in India, very often we found a sterilizer with the gravity displacement, but the requirement is a pre-vacuum sterilizer to sterilize the robotic instruments. These were the challenges when we initiated the robotic services, or classified human, equipment, and environmental challenges. The whole team, including the surgeon, nurses, and the technicians, underwent 3-day systematic training at the robotics center. However, on a table, the experience was very different, and there was a learning curve for about 3 cases just to get the orientation and the familiarity with the icons and alarms. We bought the Versus system as it can be transported within our branches quarterly. When this happens quarterly, the redundancy of the training was a challenge. And another unique challenge in India is that as soon as the team is trained, they start applying for jobs in Europe and Gulf countries, and it is a challenge for us. We are privileged to have a clinical assistant with us since the installation of the robots, who also documents all the challenges, arm clashes, and suggestions from the team, which will be escalated to the company. And I personally feel this is needed as the system is still new, needs modification. The biggest challenge we faced in the initial days was the space constraints between the operating room. So what was the challenges in this? Initially, when we started, we used to have the bedside units on one side. If you see, all 3 bedside units were on the one side. So there was no space between the bedside units for the bedside surgeons to stand and operate. The next challenge was frequent arm clashes. The arms are coming together when the bedside units are kept alongside, and there were a lot of arm clashes externally and internally. Accessing a sterile trolley also was a challenge because after these bedside units, we used to keep our trolleys, and this was a challenge for us. We are aware that in a lateral position, usually the patient arm position is like this. But when the robotic arm comes in the upper side, it is a challenge to have a patient position like this. And we had a challenge in this also. So what did we do? We tried to change the position, like giving a swan neck position for the lower bedside unit. We tried to create a space in between. But however, it didn't work and did not solve our problem much. So finally, we came up with this 2:1 position. This is with a lot of trial and error. Here, if you could see, the 2 bedside units on the anterior side, another one is behind the patient. So there was a slight change in the port placement also. We had a sufficient space for the surgeon to stand and the bedside team to stand. And almost 80% of the arm clashes we could reduce. And we could place the instrument trolley properly. So we came up with this OR layout plans. This may actually change based on the individual surgeon's preference, but for us, it worked very well. For a pelvic surgeries, these were the positions, and there was no much challenges for us in this. So the next challenge was the cable management. You will have a lot of cables moving all across the floor, especially when you cannot have a permanent solution with a mobile robot. These were the cable management techniques suggested by the company. You can choose which one works best for you. But here, in the dicey chain and in the hybrid technique, if one bedside unit has a problem, it may have a problem for the other bedside units also. So we prefer the spider technique. And once we set up a OT, we try to strap these cables so that it won't trouble us much. Another challenge was these drape cap insert may used to come out initially. So if in case this comes out, this makes the sterile field unsterile. So we have to be careful, push this fin down and remove the instrument every time when we change the instrument. Another challenge is to remember to use the insulator for the monopolar scissor. The scissor comes like this, and there is a separate insulator, and we have to remember to put this every time. And these are not preloaded. We have to add it before we're using for the surgery. Though we have a modular operating room, the flows are not even. So these bedside units keeps wobbling. We are not able to fix it in a position. So finally, we decided to fix it with the disposable towels. We are moving towards more and more advanced sterilization technique, but as of now, these robotic instruments cannot be sterilized with gas plasma sterilizer. We use a steam sterilizer. And you all aware, the number of instruments are limited in the robotics. I think maybe in all types of robots. For us, this is a challenge because the expiry dates for the steam sterilizer is shorter than the gas plasma sterilizer. We have escalated to the company, anyway, they're working on it. With this, I'd like to thank EAUN for the entire team for giving me an opportunity to share our experience in this prestigious webinar. Thank you.
Thank you, Nisra, for sharing your experience. I'm sure some questions will be asked, as it's always challenging to set up a service at the beginning. Yeah. Second presentation is done by Pam, our surgical care practitioner in London. Pam, when you're ready.
Thank you, Martha. Hello, everybody. Like Martha said, my name is Pam Nwangwu. I'm a surgical care practitioner, and I work in University College London Hospital. We've had our robot for about, I would say, 13 years. We mostly do urology, which is prostate, bladder, and some kidney cases as well. So I've been asked today to talk about creating a successful robotic theater team. When I was asked to do this, I was thinking, what should I put in this presentation? And I'm thinking about what is success? And I was looking about it, and I found this this quote from Bill Bethel, which says the successful theater team is a group of many hands, but of one mind. And I said, okay, that suits what I was actually going to talk about today, which means it has to be people that work together to achieve the same goal. And I have to declare I don't have any conflict of interest as well. So the topic I'm going to look into today is looking into a successful team, what it looks like. And for when you ask different people, what does the word success means to them? I would say that's going to be a bit subjective. It depends on who you ask. Success means this differently to different people. So in that situation, I'm going to look at it in my personal point of view, and what success means to our team. And I also look into team dynamics. What are the dynamics that made up the team? And what do we expect when we're making up a robotic theater teams? Talk about the role of communication in a robotic team. I look into training and education as well, the impact that plays in making sure our team that we've chosen is successful. And to round it up, when we finish everything, how do we know that the thing we did is actually suitable for our team? We look into monitoring and reviewing. So what does success look like in a robotic team? I would say in our robotic team, I would consider ourselves to be having a successful team. Saying that I have to blow my own trumpet, who else is going to do that for you? So the main thing is that having an open communication. Having an open communication means that every staff is empowered to share their thoughts, to express their ideas and their issues to each other without the fear of any repercussion or humiliation. So what does that do? It's a team, it increases trust and also reduces stress among your team members. Everybody know that they feel free to be able to say what they need to say, that it makes the team very successful as well. All your team members should be able to understand their role. There's nothing difficult about people coming in your team say, what am I going to do today? What should I do? Should I do this? Should I do that? It's important that we all understand what we need to be doing. Come in the morning, everybody knows what needs to be done. What does that create? It creates an autonomy within your team members. It also allows your staff to use their time much effectively without needing to stop or clarify at any point in time. So things work accordingly, things flows. how it's supposed to be in your team. Look into your values in your robotic team. What are your values? What do you intend to do? Values are things we do. Is that okay? Values are actionable. Most of the time, we have other people who tend to extract our values for our team in accordance with your trust, your hospital, or your healthcare values. So you extract what suits your particular team. It could might make up your value could be like, is the quality of care you give your patients. Your value could be like teamwork is a dream work. So whatever your value is, that is why you have to make sure you have value in your robotic team. It's about ensuring that everybody works together. Moreover, it's good to make sure you have commitment. Staff are committed in ongoing and developing the team. If your staff are not committed, they just come to work and just go. So if they're committed, they find out that sometimes they go extra miles to make sure that your team is built up properly. So you have to make sure you have a committed team as well. Are your team evolving? Is your practice evolve? Do you evolve according to technology? Where we are, we know we have this big technology we are working on, which also changes with time. Do your team change, go around with changes as well? So when you think about all these 5 things I put down here, these are the things I think, in my opinion, that makes our team successful. We might all have different things we can talk about that makes our team successful. We might have to discuss it possibly at the end of this case. At the end of this presentation, sorry. So another thing I'm going to look at is the team dynamic. Who are the people that you have in your team? What makes up your team members? The first thing I'm going to look at is getting the right people. What makes a team successful is the people that works in that team. Do you have trusting team? If you do not, what you have are people that just come to work and they leave. Trusting team is people that if anything goes wrong, they lift their hand up and say, this is not right, how can we sort it out? If they're trying to do something they're not qualified or they cannot do, they can also say, I really want to do this, can I get training to do that? That's when you have a trusting team. If you get the right people in your team, these are the people that are reliable, dependable, and also you can trust to be able to make sure you do the right things that are done in your team. Diversity, how diversified are your people in your team? Diversity in experience, diversity in views, diversity in ideas. When you have a group of people, a team of people that are diversified, it creates a better results. Also, it considers problems from different angles and different viewpoints and different perspectives. So in that situation, if you have a problem, everybody bring in their own views. You find out that it reflects the needs of our patients and also of our team as well. So think about diversity when you're creating your team. Optimistic thinking. Why did I put this down here? It's always important that we have people that are very optimistic. These are the people that are focused on solution instead of focusing on problem. If you have people that's always thinking about negative stuff all the time, picking up this got wrong, that got wrong, and that's got wrong. Or you need people that, okay, this has got wrong. What is the solution for it? How are we going to solve that problem? So if you have those dynamics in your team, you find out that those people are always people that are looking for solution for your team. How's skill mix? What are the skills you have in your team? You don't just decide to create a team and have only one particular skill members. You should have problem solvers, people that are very good in managing their time, people that are very good in communication. So if you develop a team and have people that only have one particular skill, it tends to find out when there's a problem, you might not have people that are going to solve that problem for you. So it's always good to make sure you have a skill mix. Even the skill mix also has to do with experiences as well. If you're developing your team, make sure that people that basically maybe have 1 year, 2 years, 3 years, 4 years experiences. Those are actually going to make sure that people that have younger experiences or lesser experience, people that have more experience, we also teach those people. So make sure the skills of your team members are always mixed. So talking about the communication, now I'm going to look into what the role of communication and teamwork. So in communication and teamwork, we have to make sure that we always have a clear and simple instructions. When we have a simple instructions, it's very much easier to follow. Give an instance, when a surgeon is on the console and give an instruction like, oh, change right hand, monopolar to scissors. It looks simple, but it's a confusing message. It's not clear. But when you send a message like, I want my bipolar to change to a grasper, you know already what a bipolar is, change it to grasper. We give the other instruction, whose right hand, whose left hand, patient's right or surgeon's right or the assistant's right. So you make sure the instruction we give is always clear and very simple to follow. When communicating, how to make sure everybody's voice is heard, everybody's opinion is considered. It's not a one-man show when it comes to robotic surgery. Every member of the team voice should be heard and considered as well. Briefing and debriefing, which is very important. This has been very common in UK now to brief and debrief within in a daily basis. So we should have to impact this in our team as well. We'll talk about briefing, what we're gonna do, what's gonna happen, what we're gonna expect, and then debriefing at the end of it. Okay, did everything go well? What can we change? How can we improve? What didn't go wrong? What didn't go well? So we talk about all those things in our team. How do we disseminate information? This is actually very important. When we have any information, does everybody know about it? If you decide to change something today and just tell people that are working that particular day, that might not be effective because not everybody's gonna know that the information you give has changed. So you think about how do you do that as a team? Most people can do it through emails. They can also do it via, thank God for technology, we all have it in our hand. It could be through a WhatsApp group you've created for your team. Be very careful, you don't share confidential information there. If the information you have is confidential, you can send a WhatsApp or say, can everybody check their emails, please? So in that way, find out that if disseminating information is gone wrong, everybody can act on that information that you've already said. So think about how you share information in your team. Make sure everybody hears it, everybody knows what's happening, everybody knows the changes that have actually been taking place. So now talk about the impact of training and education in a team to make sure a robotic team is successful. Competency. Do you have a competency for all your staff members, both for your technical and non-technical? How long will the competency last for? So you might have a competency for every staff when they start. You might say, okay, you're gonna run for about 6 months, we're gonna have run about 3 months. How do you expect, when they start to be competent in what they do? After that, you have a refresher training for your team members as well. Because one thing about doing robots, sometimes we might have a training and at some point, it might be a year, we have an encounter. Possibly it could be someone do a troubleshooting. You haven't encountered that. It tends to, when it happens, you might not remember how to do it again. So always good to have a refresher training for all your team members annually. Develop a SOP, the standard operating procedures. So which means whatever your team is doing is a standardized protocol for every single person. So we're all working, doing at the same thing at the same time. Have the guidelines we all have to follow as well. Then think about surgeon preference cards. So when we do that, is always make sure that when people are not around, they know what's going to happen. They know what needs to be done. They know this is how we need to set up things. So I've been some places where people have their preference on their phone, or writing that in their own personal paper. It's always good to have it in a general place where anybody can come in and say, because there's got to be sometimes somebody's going to go off sick, and you bring a new person or somebody come and help out. So able to say, okay, fine, this is where they put their stuff, and this is where they put their Cardexes. We call it Cardex. So we're able to go there and look at it and set up the according to that surgeon preference. Conferences is also important, that we attend conferences for our staff. We create a room where our staff members should attend conferences. This is also important for networking as well, because what actually happens is when you attend this when your team members attend these conferences, they all tend to bring something new to your team, which brings in growth as well for each team members. Empowering education. Why do I put this down here? Sometimes quite difficult, especially when you haven't got enough staff to send staff for education, but always good to empower staff to educate themselves. It could be in form of study days, it could be in form of, like conference, also empowering education. Another thing I think about is helping your staff to focus on their strengths and their abilities. You could develop a system where you can tell your staff, I want you that next month, could you pick a topic and present that topic to the whole team? In that way, it builds that staff confidence that they're able to teach what they've learned to other staff as well. Utilizing robotic reps is very important. They are there for our own training as well, and they're also there to help us. So always make sure we utilize the team for the time when we need them. They're a very, very supportive team. And I'll talk about monitoring and reviewing. When we've done all these things in our team, how do we know we are successful? By reviewing the things that we've done, and by monitoring the things that we've set up. You monitor individual progress of your staff. How do you do that? You can encourage your staff to keep a logbook. With that logbook, they can see their progress from the time they started. So up to about 5-10 years, they've been say, oh, this is what I used to do there. And they can also use that to teach the younger ones or the junior ones that will come to join the team eventually. Also review your team development, which is very important, and look into what are the changes in technology that we've had. These are the things you can find out from our robotic reps. They will tell us if there are things that have changed. You contact them and say, oh, I heard this from this particular hospital, what's going on? They will keep you up to date. And that's why when they visit us, we can also ask them, is there been any changes that we need to do? Is there any more development that we need to do that we can implement? So that's why robotic reps are also there. And last and not the least, have a regular team meetings with your team. This actually to know, is there any changes? What's been happening? What can we change? What can we improve? Because in robotics, it's not stagnant, things move, things changes, practice changes. So in this regular meeting that we do, we know what the practice we need to change and how we can improve our team. So these are my references I've put down here. And these are our beautiful team, and just a few of them. They all look so smiley. Thank you.
Thank you very much, Pam. Really nice presentation. Thank you for bringing up the importance of the human factor when you're working in a team, and the importance of confrontation and talking, the communication behind having a successful team. We will talk about this later at the end of the third presentation, so we can discuss further. And now we have our third presenter, Claudia. She's a surgical care practitioner, also based in London. Claudia, the stage is all yours.
Thank you very much, Marta. Thank you, Pam, and thank you, Nethra. Both of you have done all the hard work. Nethra has gone through all the challenges when you build a new team, get a new robot, and then Pam has gone through the hard work building a successful team. Now, I want to share with you today our experience in my hospital how we extend it from one specialty to a multi-specialty robotics program. But first things first, I have to disclose I am on the Intuitive Care Team Advisory Board. I work for a private hospital group in the UK. We are the largest private robotics provider in the UK. We have 7 Da Vinci Xi robots across 5 hospitals. We started robotics in 2005 with urology for quite a number of years, until about 8 years ago, we started doing some gynecology, and now we cover urology, gynecology, upper GI, HPB, colorectal, thoracics, and ENT. So how did we do it? First of all, we treated robotics as a service line, just like urology or orthopedics. That means that we have got a dedicated robotics team. And what we then do is we build on that team expertise. We build on these technology experts, and we added onto our team's specialty experts from other specialties. We also reviewed our emergency crisis management protocol. This is our emergency DDoC, a cardiac arrest, major hemorrhage, controlled or uncontrolled bleeding, airway issues, or machine failure. When we're expanding, we need to look at our inventory management, and also we need to look at session utilization. How do we stop consultants from different specialties fighting with each other to use the robot? How do we maximize the use of a robot? We ended up moving all non-robotic cases out of the theater. And also we constantly review our program to make sure to see when it is time to get an extra robot. Now let us drill down into our robotics team. I have mentioned just now that we pull in specialty expertise. Surgical trainees end their training with robotics. It is the same for us with our theater nurses. A theater nurse with us would have rotated through all the specialties before coming to robotics. We require them to have at least 18 months of open and laparoscopic theater experience before coming to the robotics team. And when we first start doing a new procedure or a new specialty, we would always go to other hospitals for case observations. Robotics, although probably about 20 years, it is still relatively new, and there is always something to learn from seeing how other people do their robotics. We need to think about patient positioning, the same as when we first start robotics that Nethra has mentioned. We need to think about our room layout. Where should the surgeon's console be? From which direction should the robot come in? Because positioning might be different. Now, is the assistant going to be sitting on top of the scrub nurse? Next is our emergency crisis management protocol. I cannot stress how important it is to have regular simulation training, and we train as a team. At our hospital, we run emergency simulation training every 6 months. This is mandatory, and we need to include our surgeons and anesthetists. It is a team effort and team event. Let's look at our inventory. With a multi-specialty robotics program, we carry a larger and a wider selection of instruments. So we need to think about storage. We need to think about whether it's more efficient for us to single pack these instruments, or should we make up new sets? For example, do we make a colorectal set with maybe a hook? Should we make up a new ENT set with a spatula? Are we going to be using some new advanced energy devices? any stapling devices, we need to organize additional training for all these new advanced devices. So to sum up, for our hospitals to successfully extend from one specialty to a multi-specialty center, we treated robotics as a surface line. This gives us a dedicated robotics team. It gives us a dedicated robotics theater. The makeup of our team includes a technology expert, that's our robotic expert, and a specialty expert. And we do regular simulation training to ensure that everyone knows what to do when there's an emergency. Thank you very much. And I'm happy to take any questions.
Thank you, Claudia. So it's not just about we have a robot and now we operate. It's much more complex than that. From how do you fit the robot in the room to do we have the manpower to manage the robot safely? And where are we going to store equipment and what do we need? Very important topics that all of you have been, raising tonight. Anna, do we have questions?
We do have questions. I think this one, the whole panel will be able to answer. The first one by Corinne. This is more to do with creating a successful team. Do you think a successful team is the solution for the OR nurse shortages? Because she says in her hospital, they've had to cancel surgery because of this issue in terms of training.
Well, in my hospital, training new members of the team, it's an ongoing challenge. As mentioned tonight, having a regular team does help. But yeah, we need to expand our teams and make sure that we are all aware of, the routine.
I think from my experience, having a dedicated robotic team is always very important. Although if you have your core robotic theater team, then you have people that when those core are not around, they can always come and help. So having those core is actually very important. And then you train people. And I found that when you have those core, you keep them for a while before you now start. When we started doing this robot 13 years ago, we only have about 4 or 5 staff that are core robotic team. Then we spent a year, just about 5 of us. And then from there, we start bringing in people in to start training them. But shortage of staff is not helping at all, because when you want to train somebody else, somebody has to go out to be able to train somebody else. It would be difficult to get that done. So to do that, it is difficult, but it can be done. You just have to think about how we're going to train that. That's when you have to have your competence. You want a competence to be 3 months or 2 months or 1 month. In that way, look, if this person is coming to be trained within a month or something like that. So you have a timeline when you're going to train that person. So if you might do that, do you want to train someone that already experienced before, possibly doing urology, have someone that you experienced in doing urology. So it's much easier for the person to not, you won't come to start learning the anatomy of what's happening. You don't learn about how the robot works. If you bring someone that doesn't know about anatomy of urology, so you train a double, it's like it takes longer to learn the robot and learn the anatomy. So you have to think about how do you want to start to do that? Claudia, what do you think? I see you shaking your head.
I agree with Pamela. Then first, initially we have a set of training team. And then what happens? They have to be posted only in the robotic theater. And then continuation of the training is a challenge. So we have to build a team as a second line, third line. They may go on leave. So we cannot have a fixed number of staffs, and it becomes a challenge when we go on leave. We may have to postpone cases, and it has happened also. So it's better to have a backup team as a second line who has been trained at almost with a similar competency level.
Yeah, I completely agree with you and with Pam. I was nodding my head because yes, we need to have a comprehensive competency pathway on how to train team members. But also, in my experience, we always change one denominator. So if I've got an expert surgeon, an expert anaesthetist, an expert scrub nurse, I can bring in a not so experienced circulator. If I have got a very junior scrub nurse, I would have a very experienced robotic expert as a circulator. So change one denominator at a time.
Yeah, we do apply that as well. And first thing that we say to the new nurses, the new member, is that communication is the key here. If you don't know, you just say it, and we are all here to support and help. And that's the only key, I believe, to avoid disasters and to have a successful team, and at the end of the day, to go home safe and happy. Any more questions, Anna?
There's quite a few. Claudia, this one is directly to you. How does the competency assessment workbook in your hospital, and do you have a standardized competency booklet?
Yes, we have. So we have industry online training. Then we have an industry in-service training, i.e. You have a dry run of how to use the robot hands-on training. And then we will stipulate that the person, whether the person is a circulator or scrub nurse, they have to consecutively run for 10 cases, then scrub for 10 cases. And they have to keep a minimum amount of cases that they scrub for every month.
That's pretty comprehensive.
Yeah, and every year, sorry to butt in, every year we do run a boot camp as well, and that is Pam's refresher training. Yeah, we all take a day off to go boot camp.
Yes, we all do. We all do. We do run these. Anthony, one of the attendants, he wanted to know, do we have like a standardized competency training pack specifically for robotic surgery? And I know, as you answered before, it was obviously industry training, but a lot of it is kind of writing it yourself in the beginning, but try not to reinvent the wheel. You know, we are all happy to kind of guide you and that sort of thing. We've written competencies before for our own hospital. So if you kind of reach out to us, we're happy to share that. Something's already in place. Let's not kind of do something else because it will do the same thing. I hope that answers that question. And I know, Anthony, you said you're a new SCP in neurology, and is there any training available in the UK? This is something that I'm quite passionate about, as well as Pam, well, all the ones that are here anyway, in terms of training, because we do believe training is the key. There are certain centers that do specific training. I know there's one in Newcastle. I know UCLH did training as well. So there are things there about, but they had stopped for COVID, and I think people are kind of slow in starting now. But I think if there is definitely an appetite for it, we can definitely kind of create one between the girls. I'm sure we can create one ourselves. So hopefully that answers that question. No, this is a really interesting question.
Hopefully, no, sorry, Anna, sorry.
Mm-hmm.
Hopefully also someone in Europe maybe already have done something similar. Maybe they can share with us if anyone is aware. So reach out.
In Europe, there's the OC Academy, but I'm not sure what their intake is like. I think it's, Claudia, you've been to that one, the one in OC.
So the Aussie one is really like the intuitive one, but I was gonna suggest the one in Denmark, Aalborg, run by Jana or Joanna. We can post it later, details. I don't know because it stopped COVID. I don't know if they have resumed.
And I think that's kind of the main issues, because with COVID, everything kind of stopped and you're not sure One, if people are starting back their programs, and actually a lot of the programs are changing now in terms of how they run it. People are, I guess, a bit more fearful of travel, which I don't understand, but hey. Maureen, you had a really good question. What are your opinions on SCPs having dual roles on some occasions about assisting and teaching staff simultaneously? When I read that, I see dual roles in terms of you're assisting and I have a trainee SCP next to me. That's what I read from that. So I think, yes, it can be done, but for specific cases. And I do think you kind of have to know your surgeon, because people have to learn. You can't teach you can't teach this in a lab. You do have to have physical patients. When I train, I do modular teaching, similar to that of the surgeons when they do it. So when you get one bit right, I let you go. You get the next bit right, I let you go. If something's a little bit more kind of juicy, I'll take over, but I will still be in the room, but there'll be parts of it I will leave you to do, because you have to learn, and you have to learn by your mistakes, not necessarily like, you know, disastrous mistakes, but just like, oh, okay, you know, you're in the surgeon's way, bring your suction back. So it's just little things that you're there to guide. So I do think, yes, it can be done, but you do have to pick your patient, pick your surgeon, make sure he's in a good mood that day.
And I really push my trainees to use the box trainer.
Yeah, yeah.
You know, if you spend 50 hours on a box trainer, I think it is worth it.
So Anna, is it talking about Maureen talking about SCP train another SCP? Is that what she's trying to say?
That's what I gained from that.
Yeah.
Yeah. But
yeah.
if it's not specific, then
yeah, I think it's okay, because we found that when an SCP train an SCP is quite totally different than when a surgeon train an SCP. It's totally different. When you train, as long as both of you are scrubbed up, so you know that you can always jump in, when things are not going okay. I think it's all right.
Yeah, and if Maureen means teaching staff as in nurse or circulator, I think it depends on the experience of the SCP and the complexity of the case. I think from an experienced SCP point of view, we are in a very good position to lead that theatre, to encourage scrub and circulator staff.
Another question. What is your view on robotic programs without dedicated SCPs or assistants, i.e. programs that depend on junior doctors that rotate regularly to run robotic lists? Well, I know what my answer is. Me personally, I do think robotic programs run well or run better. The team is more efficient having dedicated assistants. We will be there doing this day in, day out. I can read my surgeons like the back of my hand, so I know exactly what they're going to do. And I also know when they're training, what they will allow the trainee to do. So I think it is kind of building up a system where it is good. I must say, I've been quite fortunate where the junior doctors that I have trained or been part of their training, they really appreciate having a dedicated assistant, because they get to go on the console. For them, it's like the key. It's like nirvana. They're like, yes, there's somebody there and I don't have to do it. And I mean, nobody really wants a consultant. When was the last time that a consultant kind of done laparoscopic work, really? I don't know. I'll take my chances on that. What do you think, Claudia?
I agree with you totally. Do we have any surgeons in the audience? Yes.
I agree with Anna, but it's very difficult without a dedicated team. So in the first years, it is all the icons. It takes time for them to recognize, even with the training, it takes time to recognize and act immediately on what icon, what action has to be taken. So if the team is not dedicated and not trained, I don't think it is feasible to operate with.
Okay, just another question. Are there any plans to create a standardized competency for robotics, like the Capital Nurse Passport, one that each practitioner can take with them to different hospitals? I agree that that needs to be done in terms of standardization and competencies that people can take, but I think it'll have to be something that we do with, that's something that's recognized with a university or whatever, because a lot of hospitals, if you do in-house training, they don't recognize it and you have to do it again. So I do think that, yes, that is something that, you know, should be done. So anybody, we put this out here, seeing as, you know, you're all here, we're trying to get new members for the specialist interest group. So, you know, we can create something. Why not? We can create something. Claudia.
Yeah, I know that this is a urology meeting, but I know the gynecologists, they have done a standardized competency.
Oh, fantastic.
So if
That's
you
good.
go onto BRIAG's website, so this is the British Association of Gynecologists or Robotic Gynecologists.
Oh, gynecologists are leading the way. Who would have thought?
They try. So yes, there is a standardized competency. It is recognized by the society.
And what I want to chip in that one is that sometimes it might be because every hospital have what they can allow their nurses to do and not to do. And in that way, when you're going to do standardized one, if it's not in your trust policy or your trust guideline to do that, they might tend to like take that route, you know what I mean? So in that situation, that might be where it comes in a bit difficult when you look at that standardized one. If it's not, you have to make sure, I don't know, though we are standardizing it, you have to make sure it's actually also a policy in your own hospital to make sure that actually you have to be able to do it in your hospital. Unless it's just like a general stuff when you come to, you can do it. Because when you think about it, there's some hospital that will not allow a scrub nurse to insert an instrument. You know what I mean?
Yeah.
Although they be trained. There's some hospital, yes, we can do that as long as we train you and put in our policy. You know what I mean? So there they can do that. So that's where it's a bit difficult. That's why it's not, some people will ask if I will train you here, but that does not mean you can do it in a different hospital. You can always do it in her hospital. That's why you're covered.
Yeah, and I think that's to do more with their policy in terms of vicarious liability. So it depends on what's within your job description. So ideally, they would have to kind of write it within your job description so that you're allowed to do this, so you're covered. But again, you know, robotics is kind of everywhere.
Now leading the way.
So should we be kind of looking at it from that point of view where this is something that's not going away? How do we empower staff, make it safer for everybody by having this? So it's, I think it's a good thing. Yeah, I think it's a good thing.
But think about also the country where nurses are not allowed to assist, or they are doing it without having any sort of course. This is the main point. You have to have it on your job description and on your contract, just for an insurance reason. Because when things happen, you know, you have to answer.
That's a good point. I think that will definitely help. So somebody's mentioned the new RCS curriculum that's gone out. They've actually put robotics on the curriculum, which is amazing. Because when I trained back in the day, it wasn't there, and I had to create my own document with my robotic competencies to put into my my booklet and my SOP and my jobs. That's I think that will definitely help. But I do think what's missing is kind of people doing and having dedicated time to learn and to kind of do. It is hard because you get your job and you're just like, yeah, okay, this is what I do, I do think it'll definitely help people a lot. So this webinar was kind of devised by, you know, us here in terms of, we kind of wanted to do a webinar about robotics. but we don't know what other people want. So we would love suggestions for webinars that you would like to see in the future. If you've enjoyed this one and think, yeah, okay, or maybe you want to give us a topic and you want to talk about a topic. So because we are trying to do more educational stuff, because I think the key, like everything else we've kind of said today, is about education and about building up teams. So I think that kind of goes hand in hand. Martha kindly put up a QR code earlier today. So if you can, if you're interested in joining the SIG group, we are fun, as you can tell. We're in Milan, and we're also planning the EROS program, so the European Robotics Urology program for the nurses in Florence in September. So if you are interested, you know, do give us a shout, or you want to come along, let us know.
Okay, so we need to remind everyone that this is an accredited course, and you will receive your certificate of attendance once you've done the questionnaire that will be sent to you over email tomorrow. And we need to thank CMR Surgical for sponsoring this webinar. And I wish you a good rest of the evening. Should we close here?
Yeah, thank you all for attending. Hope you had a
Thank
good time.
you.
Thank you very much.
Thank
Bye.
you.